I'm Laurie Sehn from Vancouver, Canada, and I'm here today with my colleague, Dr. Jennifer Brown. Dr. Brown has an illustrious career in CLL. She is the director of the CLL Center of the Division of Hematologic Malignancies at the Dana-Farber Cancer Institute, and the Worthington and Margaret Collette Professor of Medicine in the Field of Hematologic Oncology at Harvard Medical School in Boston, Massachusetts. She's had an excellent career focusing on CLL. She has an active both clinical and translational research program in CLL. Her interests have included the development of novel targeted therapies for CLL, as well as CLL genomics. And she has published more than 335 papers focusing on this topic. So we know that there have been a lot of changes in the management of CLL over time, and you've contributed to a lot of the literature. But what do you see in terms of the current use for BTKI upfront therapy, or continuous use of BTKI upfront therapy for the management of CLL?
I think we'll definitely see it decline with the advent of more time-limited therapy options. The patient population where I think it's going to last the longest, continue for a while probably, is the P53 aberrant patients in particular. Those patients, if they get time-limited therapy, do seem to have earlier relapse, more so than any other patient population. Whereas with continuous BTK inhibitor, we have with all three covalent inhibitors, 6-year PFS on the order of 60% or so. And for all patients, actually, we have long-term follow-up of ibrutinib from RESONATE-2 and Alliance, where a median PFS hasn't been reached at 6-7 years. It may actually be 8 or 9 years. And Elevate-TN with acalabrutinib, 6-year PFS is 62%. If you add Oben, it's 78%. And zanubrutinib, 76% at 5 years. So there are a lot of data supporting continuous BTKI, but the problem is the patient has to stay on the drug, the patient has to tolerate the drug's expensive, and all of those things make it less appealing for the majority of the patients.
Yeah, so currently, in Canada, we are limited by what's funded. So we're fortunate enough that we actually have upfront BTKIs funded in BC, where I work, as well as all of the provinces across the country. We do have both acalabrutinib and zanubrutinib funded, and I'd have to say they're used interchangeably. Often we bring in the patient in the discussion regarding their preferences, but the downside, as you said, it is continuous. There's significant cost associated with it. But I would have to say that for my own patient population, I agree with you. Currently, the patients we're more likely to give upfront continuous therapy to are those patients with 17p deletion, where we think there's probably some advantage in keeping the therapy going. So moving forward now, there's a lot of interest in the concept of the combination of BTKIs and BCL2 inhibitors up front. So there's data that's been emerging. How do you perceive the current data on the combination of BTKI and BCL2 inhibitors up front?
Mm-hmm. Most of the data, as you know, for a long time has been with ibrutinib venetoclax. And my perception of that data was that the 3-year progression-free survival rates were very similar to what you see with venetoclax obinutuzumab, but you're using your two best mechanisms together, not saving one, and you're also subject to ibrutinib toxicity, which includes significant rates of cardiac problems, just more irritating side effects like arthralgias, myalgias, fatigue. And so personally, I am not really interested in using ibrutinib venetoclax. And we did just report the Amplify data, which is the registration trial for acalabrutinib venetoclax with or without obinutuzumab compared to chemoimmunotherapy. So the acalabrutinib venetoclax combination was really quite well tolerated in that trial. And so that will be becoming an option where I wouldn't feel that the safety was an issue the way I do with ibrutinib venetoclax. We still don't have that much data about, say, retreating with the same combination later and whether there will be acquired resistance, but I'm a little less worried about that than I was because there's more accumulating data that, for example, you can at least use continuous BTK after the combination of the two, presumably venetoclax as well. More and more data will accumulate that on that issue in the next few years, I think.
So we haven't had a lot of experience with a combination of finite therapy with BCL2 inhibitors and BTK inhibitors as a combination up front. So I'd say that we're on the verge of getting funding for ibrutinib and venetoclax. A few patients have gotten compassionate access, but I think there's been a lot of reservations on the part of clinicians to go back to using ibrutinib, even though that might be a compelling, finite, easy-to-use combination. So, right now I think the verdict is still out on where those combinations will fit in Canada once they do become available. And as you said, I don't think we have a good grasp for what the long-term outcomes of that type of approach is and how we might manage patients at the time of relapse. But you mentioned the AMPLIFY study, and that actually had a 3-arm design. So it brings in the concept now of triple therapy up front in a finite way. And what are your thoughts on that?
Right. Well, I think prior to AMPLIFY, it was hard to know what to think because we had a lot of parallel phase 2 studies, different patient populations, and you couldn't really even tell the difference really between outcomes with 2 and 3 drug regimens. Now, it was not a planned comparison of AMPLIFY or a comparison at all to compare the 2 versus the 3 drug regimen. But it's hard not to notice that the 3-year progression-free survival of the 3 drug regimen was 83% in all comers, and if you censor for the COVID pandemic, it's 91%. And that held up even in unmutated IGVH patients, whereas the AV arm was 76% in all comers, and in unmutated patients dropped to about 68-ish%. So the very high rate of 3-year PFS with AVO, combined with the fact that the undetectable MRD was almost universal, it was 95% in evaluable patients, has convinced me that that is an effective regimen, and it's only 14 months as well. So there's this subset of young patients with unmutated IGVH, many of them have 11q deletion, bulky adenopathy, who I have felt would not do well with ven-oben because bulky adenopathy is a risk factor for not doing well with ven-oben, and they have relatively aggressive disease. So those patients I've been starting to use a triplet regimen, which seems to be quite successful so far, but it's pretty early.
So, we haven't had the luxury of using that combination yet. I think that it's not clear to me where the triple combination will fit in the Canadian environment. I think it'll be a little bit of a challenge to possibly get funding for the addition of the obinutuzumab as well, because there was toxicity concerns, albeit related to COVID, which may be a little less of a concern now. But at this point, I'd have to say, I think the combination of AV is certainly very attractive as an option up front, but whether or not we'll have universal funding for the triple combination or it'll have much uptake on the part of Canadian clinicians, I think remains to be seen for sure. But there are real limitations in designing these upfront trials in terms of continuous therapy versus finite therapy, and what do you see as the main limitations in knowledge right now based on the trials that we have?
Well, we have no comparison between time-limited and continuous therapy with a targeted agent. The first trial that we're waiting for is CLL 17 from the Germans, which uses ibrutinib, which may mean that the outcome will be strongly affected by toxicity issues. We don't know. I think we'll still be able to learn something from it. That trial, of course, compares ibrutinib with ibrutinib venetoclax, 15-month regimen with venetoclax obinutuzumab. Somehow we've been accepting comparison of continuous BTK inhibitor trials that compare to time-limited therapy. And initially that was chemoimmunotherapy, which is probably how it came into vogue. But it is sort of a problem now when we think about how do we compare our targeted agents with time-limited therapy to continuous therapy. It's not really fair to compare first PFS, even though that's usually the primary endpoint of the available studies. We really should be comparing the total duration of benefit from that particular mechanism, which for the time-limited therapies could include retreatment. At least second PFS after retreatment we should be evaluating. But it becomes logistically very complicated and expensive to follow that in large trials.
Yeah, I think, obviously we'll learn more from all of the trials that have been done, and some of the ongoing trials, of course, I think will answer relevant questions that are pertinent to the regimens that we're using today. But certainly right now, I still have reservations not knowing what the long-term value is of sort of throwing multiple novel targeted agents up front versus stringing them along, what that actually does to the development of resistance or the reduction of the development of resistance. And I still think that when all of these options are available in the Canadian environment, they are going to require some detailed discussions with the patients where, most patients really want to know sort of, what's the best regimen you can give me that's the most tolerable regimen, and how am I going to do the best in the long term? And I think that, there's clearly going to be more data coming out on that.
Right, at the moment, we mostly have the short-term efficacy, and that's mostly what we've often had. But it would be nice to have more data about how the sequencing ends up impacting on outcome.
Mm-hmm. So thinking about where the field's going, we've seen big advancement with the availability of second-generation BTKIs. We now see trials going on with second-generation BCL2 inhibitors. Are you excited about that?
Yes, very much. So sonrotoclax in particular is very interesting. It has tenfold increased potency compared to venetoclax, and it also works in vitro against the most common resistance mutation, which is G101V. So far, there hasn't been any TLS in phase 1. And the rates of undetectable MRD are much higher than we've seen with other BTK and BCL2 combinations. Now, maybe that's just because this is a large phase 1 study done in centers, et cetera. We don't have the diversity of data that we have for the other BTK BCL2s, but that'll be really interesting to see how that holds up in phase 3. And there's also another drug, lisafdiclax, which also looked very good in phase 1 and is quite potent, and that's in registration trials as well.
Yeah, so I agree. I'm certainly looking forward to the development of some of these novel agents. I think, we've been really fortunate to have these novel targeted agents that have transformed CLL management, but the big unmet need, at least in my clinic, are those patients who are now defying BTK inhibitors and BCL2 inhibitors, and we really need, compounds that overcome resistance in that setting. So what would you say is the main endpoint in a trial that you base your treatment decisions on? What's most influential for you?
Progression-free survival, definitely. Overall survival sometimes can be of interest, but I think needs to be evaluated carefully because sometimes there are only a handful of deaths and they may be due to car accidents, which is probably not the fault of the drug. So really progression-free survival. I think the patients value that most also. Obviously, they also want something that's tolerable and has a good quality of life. Fortunately, in CLL, we have such an embarrassment of riches of drugs. We can usually manage to do both.
Yeah, I would agree. I think when I have a conversation with my patients, they first say, what's the best treatment you can give me? What's the downside? And then we get into the nitty-gritty about the logistics of administration. How are they going to feel on treatment, and what's the convenience factor or inconvenience factor for them, and how does that fit into their lifestyle? But as you said, we've got lots of choices. It does require a discussion, and I think there'll be clearly more choices moving forward. I think the big thing we're all talking about, as we said, is the finite combination of BTKI and BCL2 inhibitors, and be really interesting to see how that rolls out moving forward. So this conversation will continue as the data evolves, but I really thank you for joining me today and discussing this topic.
My pleasure.